In today's video we will discuss about a case of lower eyelid reconstruction. Now as you can see that we have a case of pigmented BCC. It is almost like a spot diagnosis in this particular case. So what we will discuss is, we will discuss the excision, the defect after excision, what options do we have for reconstruction, what is the best possible option, what we did, and if something could have been done better to improve our outcomes. So I think that would be the outline of this video. Now as we all know, this is a BCC of the lower lid. We would have roughly around 4 millimeters of margin around this lesion, which would give us a clear margins post malignancy all over. So I think post excision we will have this much amount of defect. Just for the sake of easier demonstration, I am marking it a bit extra. So now our defect would have entire length of the lower lid, or I would say almost 90% of the lower lid. Some amount of area at the lateral canthal might be preserved, but definitely not in the medial canthal region. The defect would comprise of the anterior lamella as well as the posterior lamella. It means that there is defect of the skin as well as orbicularis, which is the anterior lamella, and the defect of the tarsus and the conjunctiva, which is the posterior lamella. This is the transverse dimension. Width wise, this I think is a fairly narrow defect, I would say. The vertical dimensions would be around 7 to 8 millimeters approximately. So it would be a fairly narrow defect, easier defect for us to manage. Now that we have understood what the defect dimensions are, what the components of the defect are, let us think about the reconstructive options we have. Now the goal of eyelid reconstruction, especially lower eyelid reconstruction, is to provide stability. The goal of upper eyelid reconstruction is to provide mobility. So here we have to provide stability. Our goal here is to provide anterior lamella as well as posterior lamella. Now the main principle of eyelid reconstruction is at least one of the